Today I am presenting clinical guidelines for physical therapists and physical therapist assistants to use with patients who are undergoing rehab post-reverse total shoulder arthroplasty. These guidelines are based on the current literature as of February 2018. I believe it is important to create a set of clinical guidelines physical therapy professionals can use to provide safe and effective treatments, as most of the current literature focuses on the design of the implant and not the post-surgical interventions, such as physical therapy. The objectives of this presentation include reviewing the indications for a reverse total shoulder arthroplasty, the who and the why a patient needs the reverse approach, comparison of the traditional versus the reverse replacement, the history of the reverse total shoulder arthroplasty, the changed kinematics of the reversed implant, how this translates for PTs and PTAs, and the evidence-based clinical application and guidelines. As with all arthroplasties, the primary reason a patient undergoes a joint replacement is because severe osteoarthritis has rendered the joint painful due to bone-on-bone rubbing. The reverse total shoulder arthroplasty, also referred to as the RTSA, is becoming a more common alternative to the traditional shoulder replacement approach, and we should expect to see more patients with the reverse approach in the future. The Journal of Shoulder and Elbow Surgery concluded the RTSA procedure now accounts for at least 1/3 of shoulder arthroplasties being performed and is used to treat at least 1/4 of the humeral fractures that patients present with. It is imperative that we understand the biomechanics of the reverse approach so we can provide safe, effective, and knowledgeable physical therapy intervention. We know that the most common indication for a joint replacement is osteoarthritis, but what makes the reverse approach necessary? Rotator cuff insufficiency is the primary indication for why a reverse total shoulder arthroplasty is a more suitable option for some patients. The loss of stability in normal force coupling, usually generated by an intact rotator cuff, will leave a patient with an irreparable rotator cuff without functional movement after a traditional implant, even if they have achieved pain relief from the osteoarthritis. Another indication is a humeral fracture, as this implant can provide a stable surface for the fracture to adhere and unheal. And thirdly, if a patient has poor glenoid fossa bone stock, then the traditional implant would be too heavy and the reverse implant becomes a better option. Here is a great picture that compares the traditional implant versus the reverse implant. As you can see in the traditional implant on the left, the bone stock of the glenoid fossa has to be more sufficient to properly heal and support the joint. The RTSA approach does not require the bone stock to be as sufficient to safely support the new joint, thus making it a successful option for patients in this position. Also, the tensioning of the deltoid will help to counter the weight of the stemmed implant by creating additional stability. A brief history of the RTSA is helpful to understanding the differences between the traditional and reverse implants. The RTSA has been around for over 40 years. The traditional arthroplasty has been around since 1893, but the first reverse total shoulder arthroplasty was attributed to Dr. Neer in the 1970s. And although he was a well-known and respected surgeon in the United States, the RTSA procedure was not FDA approved in the United States until 2003. He designed the reverse implant in answer to the insufficient rotator cuff problem and the resulting lack of functional motion that he found in his patients after a traditional shoulder arthroplasty. As Neer's findings became known, many other reverse implants were designed to also counter the lack of strength and stability that was needed to allow the prime movers of the shoulder to engage. But there were significant problems with each, namely loosening of the prosthesis and the glenoid notching, which we'll discuss in a minute. The foundation for the RTSA really began to change in 1985, when French orthopedic surgeon Paul Grammont redesigned the variations of the reverse implant. And it is his 4 fundamental principles which continue to be the foundation for all current implants used. His 4 fundamental principles state that you have to ensure the prosthesis is inherently stable. The weight-bearing part must be convex and the supported part concave. you have to align the center of the sphere at or within the glenoid neck and ensure that the center of rotation is medialized and distalized. In the normal shoulder, the intact rotator cuff provides anterior balance to the supraspinatus and posterior balance from the teres minor and infraspinatus to stabilize the glenohumeral head during elevation. But the RTSA has completely changed the kinematics of the normal shoulder. Starting with the medialized and distalized positioning of the glenohumeral center of rotation. The benefit of doing this is that it is necessary to counter the loss of rotator cuff stability and insufficient supraspinatus compression of the humeral head. One downside is that medializing and distalizing the glenohumeral center of rotation does increase a patient's risk of glenoid notching and impingement. This picture will help us to better understand the risk of glenoid notching. Here you can see how the inferior aspect of the implant has the potential to literally notch into the scapular neck, which can loosen the implant. This was one of the most common problems that occurred in all of the first reverse implant designs. Even the newer designs are susceptible to causing glenoid notching if the offset of the humerus and the center of rotation is not properly determined. And even then, having a fixed center of rotation is still going to increase a patient's risk of glenoid notching. It is something important to remember as our patients rehab. If they experience sudden or significant increases in pain, it could be due to glenoid notching or loosening of the implant. We'll take another look at a slide in a minute that will show how the deltoid that is tensioned will also act to help counter the potential for glenoid notching. Another change in the kinematics of the reversed shoulder is the increased function of the deltoid. The deltoid is tensioned in such a way to help counter the loss of the rotator cuff stability and generate flexion forces through the posterior fibers of the deltoid. The teres minor also now plays a new role in elevation, which is to balance and stabilize the upper extremity when it is elevated. This picture helps to drive home the changes that a fixed center of rotation brings about. Because the center of rotation in the reverse shoulder is now fixed, the deltoid has to have increased force to elevate the arm. On the left, you can see how the lever arm times the force requires much less torque than in the replacement joint on the right. You can see how the lever arm distance, the yellow L line, is longer, and the result is the force of the deltoid, the red F line, now is also increased. And if we remember that lever arm distance times force equals torque, we can see easily that the amount of torque to abduct the arm has significantly increased in the RTSA shoulder. The surgeon will tension the deltoid to improve the arm's ability to counter these changes, which not only help to create more functional movement, but also helps to decrease the risk of glenoid notching due to that lateral pull. Now that we have a better understanding of the kinematics of the reverse shoulder, we need to see what the literature-supported requirements for successful rehab are for the RTSA. The current literature has 3 common requirements that are needed for successful rehabilitation post-RTSA. First, as short of an immobilization time as possible. Second, early and active functional movement. And then setting appropriate expectations for outcome. So how does this translate for the PT and the PTA? Well, first we have to protect the reverse joint from the increased risk of dislocation. Because the center of rotation is fixed as well as medialized and distalized, the patient is now at a greater risk for dislocating inferiorly in that shoulder. So you have to avoid positions and exercises into internal rotation, adduction, and extension. We want to avoid activities that couple those movements for up to 12 weeks. But we will allow functional usage into these positions after 4 to 6 weeks, but without adding the stress of passive range of motion. It is also helpful to understand that the joint is most stable in 30 degrees of external rotation. Unlike with your traditional shoulder arthroplasty, which avoids external rotation at first, the RTSA joint is most stable in some external rotation. Setting up appropriate expectations are an important factor for having a good outcome. We want to make sure that both the patient and the therapist have appropriate expectations for rotation and flexion that's going to be gained. Active range of motion flexion from 105 to 120 degrees is considered a good outcome, just as 30 degrees of active external rotation is considered a good outcome. Now you will have patients that will gain a lot more motion than this, and then you'll have other patients that barely meet that threshold, but those patients will all still be considered to have a good outcome for the RTSA. It is also important to remember that gradual strengthening of the deltoid and scapular musculature is really important, but too much too early can cause joint instability. So we want to promote the force couple of the scapular musculature throughout the trapezius and the serratus anterior. This provides the necessary upward rotation to allow abduction of the humeral head and the glenohumeral joint without excessive superior migration of the humeral head. This is especially important as patients with RTSA are susceptible to impingement syndrome. We also want to pay attention to the proprioceptive abilities in the shoulder. Studies have shown that patients with both traditional and reverse implants have deteriorated proprioceptive abilities. But when scapular stabilization is appropriately addressed, that reaching movements then can improve to functional mobilities that are smoother, offer smoother reaching patterns, and have less compensation. So by 4 to 6 weeks, we want to begin active assistive training in the plane of the scapula, and that should be emphasized at this time. Use diagonal movements to create function and promote some rotation. Because rotation is very limited because of the lack of a sufficient rotator cuff, we also want to make sure we emphasize the posterior deltoid. Working on the posterior deltoid can help improve rotation and function. And then lastly, we want to focus on the reconstructed soft tissue and the deltoid tensioning for the prosthesis placement, and that needs to be considered and addressed through a lot of soft tissue mobilizations. A word of caution: in the event that your patient is having a revision from a traditional arthroplasty to a reverse arthroplasty, you need to find out if the original humeral stem was maintained or removed. The risk of having a humeral fracture increases by 21% if the original implant of the humeral stem is removed. Thus, it requires significant extra caution and most likely expectations of a significantly slower recovery. Now, most patients that have a humeral fracture during a revision, it will occur during surgery, but they still are at greater risk post-surgery, and so it's an important factor to know as a therapist. The good news is that newer implants have reversible parts, so if a revision is eventually required, the humeral stem does not have to be removed. They can remove the end cap and put on the appropriate part at that time. So let's move on to the clinical application and guidelines. We're going to have 4 phases. Phase 1 is immediate joint protection. Phase 2, active range of motion, early strengthening. Phase 3, progression to moderate strengthening. And Phase 4 is progressive strengthening exercises to independent function. So Phase 1, immediate joint protection. Postoperative day 1 to weeks 2 or 6, depending on the surgeon preference. Immobilization for the first 2 to 6 weeks. This is going to vary greatly, and this is completely based off your surgeon preference. You're going to have some patients that might come in as soon as a few days post-surgery, and some that will be in a sling for 6 weeks before they come to see you. When we do see them, we want to initiate passive range of motion, flexion and elevation, 90 degrees to 130 degrees, external rotation to 30 degrees. And we want to initiate wrist, hand, and elbow movements post-op day 1 because we want to keep that mobility functional and as strong as possible without them compromising their new shoulder. As we continue Phase 1, we're going to work on initiating low-intensive shoulder active assistive range of motion exercises post-op weeks 3 to 4. No active range of motion, lifting, or weights, and also addressing pain through the use of cryotherapy. As your patient moves to Phase 2, they will begin active range of motion and early strengthening. This typically starts post-op weeks 4 to 8. Of course, keep in mind, your progression relies on your basic rehab principles. The patient's pain, their compliance with their program, their health prior to and after surgery, as well as any surgeon protocol or preference are all going to determine how quickly your patient progresses. We're going to work on continuing passive range of motion, trying to introduce flexion up to 160 degrees and external rotation up to 60 degrees. Active assistive range of motion, with eventually progressing to active motion, flexion, and elevation up to 120 degrees depending on the patient's pain tolerance. We are also going to introduce isometric internal and external exercises. Additionally, shoulder stabilization and isometrics should be introduced. Remember that 4 to 6 weeks post-surgery is when we really want to initiate those scapular exercises to introduce stabilization. We're going to use low weight resistance towards the end of this phase, but no weight greater than 5 pounds. Deltoid strengthening and scapular strengthening should begin at 6 weeks or 4 depending on your surgeon preference. Phase 3 sees your patient moving into moderate strengthening. Post-operative weeks 8 to 12. We're going to emphasize deltoid function with activities. Remember that newly tensioned deltoid is going to serve as not only an ability to rotate the arm, but it's also going to serve to help elevate the arm. So we want to emphasize the deltoid functioning properly. We also want to work on normalizing scapulohumeral rhythm and scapular stability. Full passive range of motion and functional active range of motion should also be goals of this phase. We're going to work towards rotator cuff strengthening of the available rotator cuff, band resistance strengthening, focus on proprioceptive improvements with forward reaching. Phase 4 sees the patients progressing into strengthening exercises and eventually independent function. Post-op weeks 12 and up. By this time, our patients are hopefully ready to return to functional and recreational activities as they're able. We want to set reasonable expectations for our patients on what those activities are going to look like. They might not be ready to golf 18 holes at 12 weeks post-op, but they might be about ready to get out there and start putting a little bit, or maybe even going to the driving range if the doctor gives them permission and the joint is stable and well healed. We will want to make sure the patient is also getting ready to transfer to independent exercise program at their own at home. To conclude this presentation, I want to recap what we've discussed. First, the reverse total shoulder arthroplasty procedure has risen in favor as the best option for patients suffering from osteoarthritis and insufficient rotator cuff. It is proven to be the most effective way to help introduce functional movement for patients that have irreparable rotator cuff tears. Also, tensioning of the deltoid serves to counter the loss of the humeral head compression that the rotator cuff usually provides. And the deltoid also now helps to elevate through the posterior fibers the humerus and the plane of the scapula. Additionally, the teres minor plays a new role to stabilize the arm when it's in elevation. We also discussed how the reverse kinematics of the reverse total shoulder arthroplasty pose a greater risk of glenohumeral joint dislocation due to the fixed, medialized, and distalized center of rotation, thus requiring extra caution and avoidance of internal rotation, adduction, and extension. Despite areas of caution, the literature supports as short of an immobilization time as possible, introducing early and functional movement and setting appropriate expectations of movement for the patient and therapist. Additionally, evidence-based practices emphasize protection of the joint, gradual strengthening and scapular stabilization to improve proprioception for functional reaching movements. Remember, clinical guidelines alone are never a substitute for skilled professional judgment, but are meant to provide evidence-based direction by which the physical therapy professional can provide safe and effective treatment. Best of luck in rehabbing your patient with a post-reversed total shoulder arthroplasty.